It's my pleasure today to talk a little bit about some of the findings from the 6th World Symposium, particularly as they pertain to the change in the definition and exercise hemodynamics. The new definition of pulmonary arterial hypertension that was proposed at the World Symposium is a mean pulmonary artery pressure of greater than 20 rather than 25, so we've lowered that threshold, but still with a mean or with a wedge pressure of greater than 15 and a pulmonary vascular resistance of greater than 3. Now, a couple of the members of the task force went through their populations of all the patients they'd had a right heart cath and believed that this would increase the number of patients over the years by somewhere between 2 and 6%. So it could have an effect, and there may be certain groups that it has more of an effect in. To review the importance of redefining the presence of pre-capillary pulmonary hypertension is important because we know that a mean pulmonary artery pressure between 20 and 25 is associated with poor exercise tolerance and higher mortality. And we know there are therapies that have benefited patients with pre-capillary pulmonary hypertension. Specifically in Group 1, there are drugs that target the prostacyclin pathway, endothelin pathway, and nitric oxide and SGC pathways. And of course, in Group 4, there are a number of therapies, including interventional therapies such as pulmonary endarterectomy and BPA, but also riociguat. There's really not any therapies that are approved for Groups 2, 3, and 5. But the definition that has been proposed might help identify patients with this very substantial disease who could be potentially treated earlier and have better outcomes. There is also a very interesting discussion about exercise. Many people do exercise hemodynamics, and some people believe that exercise pulmonary hypertension may precede resting pulmonary hypertension. And we certainly know that as one exercises, the pulmonary artery pressures may go up a little bit, but the pulmonary vascular resistance doesn't go up too much because the cardiac output really goes up when one exercises. But in patients with pulmonary vascular disease, you see more of an increase in the mean pulmonary artery pressure, even for the increase in cardiac output. And this was discussed in some detail by an ERS statement that was published in 2017. And what they proposed is that exercise pulmonary hypertension be defined as a mean pulmonary artery pressure of greater than 30 and a total pulmonary resistance of greater than 3 millimeters of mercury per liter of cardiac output. And a patient might have this because of unmasked pulmonary vascular disease or something early that gets brought out by exercise, or potentially an exercise-induced rise in left atrial pressure. And the wedge pressures are very difficult to measure during exercise, but I think this is really important to acknowledge because exercise-induced diastolic dysfunction is very, very common, and those patients can be very breathless, or a patient may have both. But it's very difficult to distinguish these patients. It's very difficult to perform an exercise right heart catheterization for technical reasons. There are lots of different protocols, and the group acknowledged that this is really something that needs to be researched more and have more uniform standards on. So while the ERS-ESC working group suggested that this exercise definition occur, the group at the World Symposium didn't think that this was ready for identification of patients that should be treated. But it is a very important opportunity to gain more information on the pathophysiology of the disease, the natural history of patients with exercise-induced pulmonary hypertension, and potentially even treating them. But the final decision was that it was not going to be part of the hemodynamic definition of pulmonary hypertension. So to sum up what the conversation was about the definition at Nice, again, the new definition is a mean pulmonary artery pressure greater than 20, a wedge pressure less than 15, and a pulmonary vascular resistance of greater than 3. And even though this seems like a drastic change, the number of new pulmonary hypertension patients identified would be low, with preliminary data suggesting it would be less than 10%. But it would be important to find such patients at an earlier stage. And it may provide opportunities for certain patient populations. There have been recent data in patients, particularly with scleroderma, who we screen very aggressively, and sometimes we find those patients with lower mean pulmonary artery pressures. And CHF patients, again, those patients who've had a PE and have persistent defects on their ventilation perfusion scan may be screened more, and we may be finding patients with lower mean pulmonary artery pressures. So we know in those two groups that often undergo aggressive screening programs, we are starting to find them with lower mean pulmonary artery pressures. And so this may be a potential treatment options for some patients who can really be quite dyspneic, particularly with exercise. So thank you for joining me for this conversation today. I hope you learned a bit about this important topic.